Hello, everyone, and thank you for joining us today for our third part of our discussion on mental health and homelessness. I can't quite believe it, Hunger and Homelessness Awareness Week, as we have technically finished, but we did start this series in Hunger and Homelessness Awareness Week. And if you missed part 1 and part 2, they are available on our YouTube channel. So please feel free to go back and check out the first two sessions that we did. We run Hunger and Homelessness Awareness Week in partnership with over 20 different local organizations who come together to kind of figure out what it is that we think our community needs to be talking about and what we need to raise awareness for during that time. And the theme for this year was changing the conversation. And so we had conversations about different pieces connected to homelessness. And one part that was really clearly elevated from these organizations was the need to talk about the crossover between mental health and homelessness and how one impacts the other and the other impacts the other. And so we know that there's a lot that's at play when we're discussing these two things. And so I've been just thrilled to have dialogues with professionals, with the experts in this space, and really excited to have 3 experts joining me today for a conversation to continue this going. So I do, before we dive in, just want to kind of take a moment to recognize that these topics can be hard to talk about, and they can sometimes, bring up things for us as we're watching or listening. And so if anybody is feeling that they need to access help during this conversation, I just want to kind of reference that 988 number in the video that we saw earlier today, and to just sort of bring that resource to you. That's a number that you can call to help get guided to resources specifically around mental health needs. And I just realized that I forgot to say who I am, so my apologies. I just jumped straight in there. My name is Bex Hayhoe. I am the Executive Director of United to End Homelessness with Orange County United Way. And I am just thrilled to be joined today by Heather Stratman, who's the Senior Administrative Executive with Be Well Orange County. Also joined today by Lisa Rowe, who is the Health Services Manager at the OC Healthcare Agency, and Mia Ferreira, the Director of Services for Friendship Shelter. But I want to ask them to introduce themselves, and I would just love, as you're doing that, how did you get into this field and what is it that inspires you about it? And so Heather, I'll come to you first.
Thanks, Bex, and hello, everyone. It's nice to be here today and talking about this very important topic. I don't know that I ever deliberately thought that I would step into the intersection of homelessness and mental health. I don't know about my colleagues here, but it was more of a draw to the mission and a passion for helping others, and that's really sort of what I think inspires me to stay with the effort and to help, along with the community, build a system and a continuation of care for folks who are struggling with these issues. And it feels like we're making some really good progress, and that certainly keeps me inspired. So thank you.
Thank you, Heather. Lisa, how about you?
Thank you so much. I'm super excited to be here as well. So I am a licensed clinical social worker by trade, and I think I knew even at a very young age I wanted to help people, and I really thought I was going to be helping children and doing something like that. But in some, our lives are so interesting. Sometimes I had an opportunity to work in housing with the County of Orange, and I got to experience helping people through housing and understanding how it's not just a house somebody needs, but they also need support, especially coming from either homelessness or a traumatic event or anything like that. So I think that's why I stay, because I'm so passionate about helping people, and really I get to make people are happy when get housing, right? So that's kind of why I'm here and why I stay. And I just think I'm just so happy to be part of such a great thing that we can provide for people.
Thank you, Lisa. Mia, how about you?
Hi, everyone. Thank you for having me today. Yeah, I too, my background is both in public health. So I have a master's in public health, as well as I'm a licensed clinical social worker. I came to become a mental health provider later in my career. So I've been working in homeless services for 20 plus years. And I kind of fell into it. I was a volunteer. And I knew in that very instance, there were people who had severe mental illness, and we were serving in a mobile clinic in Hawaii. And I knew these were my people. And so it's kind of been a vocation for me that to work with folks who are experiencing homelessness, and especially more vulnerable folks experiencing homelessness. I've always worked with adults. And so later on, I was like, oh, I need some more of the clinical piece, because I do recognize, and we know that there's a large portion of folks. So this has brought, even more value to kind of the way I'm able to deliver service and help develop services that, serve people who are experiencing homelessness. And I think what inspires me is, having done this a really long time, is concepts of like, functional zero, that there is hope. Right, that there is hope. We see, and Lisa and Heather, we see people get housed, and we know we can end homelessness. And so concepts like in seeing other communities actually tackle the issue, making it doesn't seem like something insurmountable, but that I really do believe that this is something, it would be what a legacy for us to be able to come up with a solution for the next generation, to say that this is no longer a problem. It hasn't always been a problem. I'm old enough to kind of go back there and have seen it kind of come to what it is. So I'm just excited to be part of this. So thanks.
Thank you so much to each of you for sharing a little bit of your background and how you got into this work. Yeah, it's always fun to learn a little bit more about people. And I began my work in this working direct service back in the UK on the outskirts of London. And I worked at a drop-in center for people who were experiencing homelessness or were housing insecure. And during that time frame, I came to start to specialize with people that were really struggling with their mental health, and seeing the impact that not having a permanent roof over their head, how that sort of interplayed with their mental health issues, and the challenges that they had in terms of trying to access services, stay on top of medications. I was very grateful to the people that I was able to get to know, who shared with me very vulnerably the experiences that they had. Our last discussion we're having was incredibly in-depth. We covered a lot of ground, and part of that ground that we covered was around distinguishing between mild, moderate, and serious levels of mental health challenges. And that was such a helpful distinction to move into a conversation, recognizing that there is this sort of spectrum of mental health challenges, and that at some point in all of our lives, we're going to experience something along this range of mental health challenges. And we've unpacked so far that this is a complicated discussion to have around the crossover of mental health and homelessness, and that there has to be creativity around the options that are provided. People have different experiences, they have different needs, and that we need to be creating systems that are able to adapt to people's unique needs. And so, Mia, I'd be really curious, when you look at the current network that we have of homeless services, what challenges are there for people who have perhaps more moderate to serious mental health concerns, and they're trying to access care? What does it look like to do that?
Yeah, I think you touched on a few things. When folks are experiencing homelessness, to continue care. So a lot of times folks will be either released from the hospital if they've gone into like a crisis, or have been institutionalized and are coming out and are homeless. This idea of, where do I store my medications, not even having shelter. So our current system, we especially in South County where my services are. We really have a lack of appropriate shelter beds for folks that if someone is experiencing a mental health condition, that would be able to meet their needs. So, for example, our system has a lot of congregate shelters. And so for people who are having symptoms of their mental illness, shelters that are more about private space, like a single room, really meet the needs of folks in a different way. And kind of when we talk more about trauma-informed care, does definitely helps folks. I would say more targeted. What we do have clinics, and we do have some resources for services, but there's sometimes a bit of a disconnect between when people are actually on the street and getting to those clinics, right? So I would say more targeted outreach. And that engagement piece. What we know is statistics show that anywhere from 50 to 60%, especially if we're talking about people with serious mental illness, in those categories like schizophrenia or bipolar disorder, may not acknowledge or understand or have insight that they have that illness. And so we know there's some best practices around engagement with folks and being able to really build relationships with people. And that takes time. And there's not a lot of funding for that kind of work out on the street to actually engage people in a meaningful way that would help them access the care, right? I think for the more moderate, one of the things we also see is that counseling services being available to people, right? So we have a lot of folks who do get services at some of our local clinics, but there isn't that option to provide that talk therapy, which so many people really can benefit from. Even if I, experience schizophrenia, talk therapy helps me. And so there's some of those gaps. And I think, this idea, what I would love to see in an ideal world, and there's some models, we're starting to see some of the street medicine pieces, but mobile mental health services, like let's bring the services to where people are, right? And I know that that's happening in some ways in crisis response, but to actually provide the service, which would be ongoing, and medications and the different kinds of things. And then lastly, I'll say, drop-in services. There was a vote to keep MHA last night in our system, which I was recently this week, I was really pleased because drop-in centers are places, because especially, in Orange County, we have this wide geographic area and people are spread out. And so an outreach worker has a hard time finding people, for example, in a city like Mission Viejo. And so having a place where people can go to be that point of access for services is key for making connection and connecting to the resources that are available to get people rides to the clinic or connected to a mental health provider or shelter services. So those are a few things that come to mind.
Absolutely. You covered a lot of ground in a short space of time there, Mia. So thank you so much. And that accessibility and the, services coming to people, it's something that I would love. Heather, I'm going to come to you because I want to hear more about what has been happening. I know that Be Well has been at the forefront in our community of really rethinking mental health services. And so would love to hear from you. Give us some of the highlights. What are some of the really great innovative things that have been happening here?
Sure. So maybe just, kind of give some context on the Be Well model is helpful, because you hit on it, Bex. It is a new way of thinking about the delivery of mental health and substance abuse services. So traditionally, if you think about across the county, these services are widely available, but they're available in their own siloed locations. So you can enter into a crisis stabilization unit, but after 24 hours, you're discharged. And in order to pick up another service, you physically have to move. At the Be Well campus, these services are all housed under one roof. So if you enter into the facility through the crisis front door, which is either a sobering center, the first in the county, the only one in the county, or the crisis stabilization unit, and you will either accept treatment or you need treatment for a longer extended period of time in a residential program, you can literally go upstairs and receive that treatment. both for substance use and for mental health. And if you have a co-occurring issue, there's also a residential unit for that. So it's a very unique model. It's unique actually to the entire state, where there aren't oftentimes all of these services housed in one facility. And it really creates a continuum of care that we don't see otherwise. I will say for the homeless population, there are, numbers of the homeless who come in through that crisis front door. And some of that is through the Be Well Mobile Crisis Program that is available in 9 of the 34 cities. If someone needs services and is identified as needing services on the street, to Mia's point, that crisis mobile response team can actually transport them to the Be Well campus in Orange. And then they can receive treatment and help. And that's a game changer, because otherwise, how would they even possibly get there, right? While they're there, through actually some work that Mia and I do together, we have been able to establish 4 full-time homeless case managers at the Be Well campus. They are there all the time. And as soon as a homeless individual arrives for treatment, they are connected with one of these homeless case managers and are offered housing navigation services, enhanced care management services. And if they're willing to accept these are all voluntary services, that starts a process of really providing a wraparound service to the individual that will go on for several months, if not past a year. And the idea there is to continue that behavioral health treatment once they've left the campus, and make sure that they have a case manager who's aware of their condition and understands their condition and is able to offer that continuation of care outside of the Be Well campus, but also to put a housing plan together, which is what we know this population desperately needs. And so it's really a multi-pronged approach that I think we haven't been able to experiment with before. And so I'm seeing great results out of it. When we watch the data, we're seeing just wonderful results because of these case managers who are literally embedded in the clinical facility. And, I think that it's something that we'll watch and we're following and we're going to understand more about. But I'm really optimistic about what we're seeing. And I think it can be a model that we expand upon in the future.
It's so exciting to hear what has been unfolding with Be Well, and just kind of the journey that Be Well has been on. And to hear that there are 4 people now that this is their sole responsibility is just fantastic. And yeah, the data that you're reporting and that ability to have this positive forward momentum, it makes sense to me. It just, we know that health, housing is a social determinant of health. And if you don't have housing, how in the world are you going to be healthy?
That's right.
So this crossover that we're seeing, this momentum that we're witnessing between the crossover between the health sector and the housing sector is just really exciting. And Lisa, with that, I want to bridge directly to you to talk about some of the things that you're seeing and the work that you're excited about.
Yeah, so I think a really big game changer for the field, mental health, was the MHSA funding that Governor Brown signed into legislation in like 2004, I believe it was. And with that, we had some money that we could use in different ways. And one way was permanent housing. And the County of Orange did a really good job. And in 2009, we built our first permanent supportive housing using MHSA money, which is the Mental Health Services Act, Proposition 1. Yeah, I can't remember now. Anyway, the Mental Health Services Act. So that was huge. The one thing though is that MHSA money is for people with serious mental illness, not mild to moderate. And I know you kind of touched on that. With that said, though, we as the county and working with developers and community stakeholders and homeless providers have just done such a great job of using all of our resources, all of different kinds of funding to really create these permanent supportive housing apartment units. And since 2009, we had kind of a slow start. We were doing as best as we could. But around 2018, we had about, I don't know, 4 or 5, maybe close to 10 properties or housing. But today we have 23 built and running. I'm sorry, 22 built and running, and we have 22 more in our pipeline. And that's a lot, right? I mean, because what you said is we need homes for people. Shelter, bridge housing or any kind, a temporary housing situation is very needed, of course, but you can't stay there forever. And I think we've learned so much with housing, because I think there in the beginning, there was almost this mindset of, just give somebody a house or a home to live in and they'll be fine. That's all they need, right? And no, like that's traumatic to move from one place to another. I just know me moving to a new house is traumatic. So if you're living with some sort of mental health disability, it's got to be so much harder, right? So we need to have the support. And I think we've, as a county, with all of our partners, have done a really good job of seeing that as a need and developing programs and really trying to help people and support people, not only just moving in, but throughout their tenancy at these properties. And so that's what I'm super excited about. I'm super excited about all things housing.
Then you're in the right job. Yeah, I mean, that's incredible to hear that we've got over 20 developments that are up, running, and there's over 20 more in the pipeline. I want to underscore those numbers and just say thank you so much, Lisa, for your leadership in this. And yeah, I want to see, I just have a feeling that you've probably got things you would like to add to this part of the conversation. So I'd love to turn it over to you.
Yeah, I mean, I think I can talk a little bit about what Friendship Shelter is doing. Is that what you'd like to hear? Yeah. So as an agency, I think one of the things that I love, I've been with Friendship Shelter 10 years and I've seen it grow and got to be part of that growth. And I think one of the ways in which we're looking at things is how do we, meet their needs and fill the gaps along the way, and really keeping a, housing first approach, as Lisa was talking about, which does 100% work. I mean, okay, 99%. A housing first approach definitely works, contrary to sometimes people, it definitely works. We've seen it. We've been in the field. The evidence is that even if someone has a moderate or severe mental health condition, giving housing improves their outcomes. And so Friendship Shelter operates over 100 permanent supportive housing units that we continue to offer those supportive services. And I really like that Lisa brought that up, because it is ongoing, right? So, we know with the changing of closing down the deinstitutionalization that happened, we do know that we are becoming that support network for people. When we house people, like, we continue with them, because we know that in order to stay housed, people need that ongoing support. And so that's been a big push for Friendship Shelter. We operate a street outreach program and an outreach program. We operate rapid rehousing. We are also, as Heather was talking about, working with Medi-Cal and supporting people with community supports and ECM, which is kind of intensive case management. And we operate multiple shelters. So we're across this continuum. We're sort of kind of making sure that the needs are met along the way. I think the other thing that is really important for us is that we've seen gaps. And so Friendship Shelter, we knew that although we could get people connected to the community mental health clinics, right, and for ongoing treatment to be seen outside of a residential, like the B-Well campus, which is residential, right? So we also have the clinics that are in the community. that oftentimes there's gaps between getting people connected or people come out of the hospital. And so we've engaged with some psychiatric nurse practitioners who are part of, are contracted through Friendship Shelter, and they provide support sort of in that interim for people. And so that's something we've done, that we just saw a need, and we've employed them to help, get people their medication right away, while we're helping them get connected to the local resources. And so that's been something that we've been doing and that we're really excited about. And I would like to just kind of say that more housing is needed. I probably should have said that from the very beginning, but more housing is needed, and it's appropriate housing, right? So we offer both scattered site, which is just apartment complexes, where we have 5 or 8 units, and then we have dedicated site. And what we've learned over the years of doing this for a long time is that folks that we've put in scattered site needed more on-site support. And so we've built or worked on having these dedicated sites where it's an entire complex, right? Where we have on-site staff, being able to support people who, and most of those folks do have a serious mental illness. Our dedicated sites really are kind of the next step for people. When it didn't work out there, we brought them here because we knew having on-site support would be the way to stabilize them and keep them housed. And in those settings, we can be more flexible with folks, and we can, kind of meet people where they're at, which is harder to do in the scattered sites. And so we need more. Lisa's talking about these new buildings that come out, and they're similar to what I'm talking about, but we need more of those. I'd say that we need ongoing places for people to go with support that will keep them housed.
Thank you, Mia. Sort of a newer terminology is always kind of coming out in our space about how we talk about things and approaches that we have. And over the last few years, we've seen the term trauma-informed care is something that has we're seeing being used more and more when we're talking about either the mental health space or the homelessness space. And I'd love to just take a moment to dig into that a bit more. And so, Lisa, could you walk us through, what is this?
Sure. So, I mean, it's being, I guess I want to say it not with like a definition, but more like from a humanistic point of view, is that we're all human and we all come with different experiences. Some good, some bad. And most likely, if you are experiencing homelessness, you've experienced some sort of trauma. And as any person working with someone in any capacity that you're serving, we want to come with that idea that this is a person who needs support, and we need to be aware that how we say things, how we treat people, that we need to be aware that might be the case, that there might be trauma there. So I guess, it's like just being human and saying, hey, I'm here to help you, and doing it in a that is sensitive and explaining things sometimes too. You might need to explain, I have to ask you these questions. If at any time they become difficult for you, the goal isn't here to help to go through the trauma again, but really to help so we can help you. And just being aware that we want to be very sensitive. I guess I keep wanting to use the word sensitive, but that's like where I come from, and just connecting with people and not just there to be like a robot or ask them questions without understanding that it's difficult to ask for help. I know I have difficulty. And that's even just going to the doctor or something. But I don't want my doctor to say something, that to me that might hurt my feelings or make me feel bad about myself. I would hope that they would be sensitive to me. So the same way when we're helping people in any kind of situation, it's really looking at, this is a person who's reaching out for help, and how can we help them and be sensitive to their needs?
Thanks, Lisa. And I do want to underscore what you were saying, you know, people experiencing homelessness have experienced trauma. It was likely traumatic events that resulted in their homelessness, you know, loss of a job, perhaps a divorce, separation, perhaps they were fleeing domestic violence, perhaps there was an unexpected health issue that resulted in medical bills that they weren't able to pay. We know that most of the reasons that people fall into homelessness are financial or family dysfunction and abuse, and those are really traumatic things, you know. Anytime something sort of threatens your livelihood like that, that's hitting us like our entire beings. And you know, and the results of trauma are something, you know, it's been great to see more conversations about that in the public sphere, more people acknowledging this. I think there's certainly a better awareness of the impacts of trauma. We still have a lot to learn as a society, but it has, I feel like over the last few years, we're seeing this sort of conversation happening more and more in public spaces, which I think is helping to reduce a bit of the stigma around that. But it is a learning curve for organizations to make that shift and to understand the impacts of trauma on the person that is now in front of them, and to we can kind of switch our models and our ways that we interact. Because unfortunately, a lot of models that have been used in the past can be, you know, they're reinforcing traumas, or, you know, forcing people to relive telling things that were really difficult. And so, Mia, I'd love to hear kind of from your team out on the front lines and rethinking and reimagining programs to become, you know, using this lens of being trauma informed. What does that look like?
Thanks, Bex. I think it's important to kind of think about what the concepts related to trauma-informed practices are. When we do that, we think about safety. You know, we think about transparency and trustworthiness. Peer support is another thing that we need to incorporate into our programming. Empowerment and choice, and being able to take into consideration cultural considerations, and then client choice and rights and responsibilities of the clients. And so those are kind of the basic tenets when we say trauma-informed practices. And so from our perspective at Friendship Shelter, there's a lot of different ways that kind of plays out. And I think from the top level, it really is a leadership and a policy perspective where, you know, we had to first make a commitment to this as an organization. So it's written into our policies, certain things like around how we do paperwork, how, you know, what kind of training that we provide, that we do provide this ongoing training for trauma informed, and that practices within at the program level reflect that. It really helped. We had to shift our lens, as you said, really to think about, and we've been doing this for many years as we were shifting towards a housing first model, but even more so to think about how do we change? How do we not make clients change to fit our programs, but how do we as an organization make changes to fit the needs of our clients? And so that's been kind of our lens and our kind of charge during making these changes for us. So looking at things like you talked about paperwork, when we develop, you know, paperwork and not having somebody repeat the same thing over and over again, how can we make that process either do it in multiple settings, because we know that this might be, you know, a lot to talk about the various things. How can we change our process so that we're not asking the same questions that get asked 3 different times in 3 different databases, right? So that's one of the ways. I think the other thing is, you know, when we started looking at physical spaces, we were renovating our shelter a couple of years back. We really looked to how can we make this take a trauma-informed lens, right? And it's about using certain colors and having plants within the shelter and really making it an inviting environment. Everything from, you know, the kind of signs that go up. If anyone's ever worked in a residential facility, you know, there's all these don't do this and don't do that, right? So taking a trauma-informed lens is you don't have those kinds of signs. You frame things in the positive and you reduce the amount of directive statements that you make to people because it doesn't feel welcome. And so you're really creating this welcoming environment. So that's the physical. We do take the stand that probably everyone has experienced trauma. So we assume that people have experienced trauma, and we try to sort of figure out ways that we can build relationship. I think that's a big piece you see behind me. These are the values of our organization, but really we are very much connected to building authentic relationships with folks. And I think that's one of our strengths as an organization, because then we can find, because everyone's different. Just because you've experienced trauma and the other person hasn't, doesn't mean that whatever your trigger or whatever what do you need, which is going to be different. So that taking a real client-centered approach. I'll give you a brief example. We had a client who wanted to record people on this audio thing, and it made him feel safe, right? And he was in one of our facilities. He wanted to audio record staff every time he had encounters. And some of our staff weren't very happy about that, but we knew that that's what made him feel safe. And we said, let's let him do it. If it makes him feel safe, let's allow him that space. And he's getting housed. He's someone who was on the street for years in Laguna Beach. And he's like, as soon as Mountain View opens, he will be housed. And it's because we created a space for him to come into the shelter. We met him where he was at. He wanted to record his interactions with the team there. We let him. That was our trauma-informed approach. We knew that he felt safer when he could record his interactions. And we thought, if it gets him housed, we'll do it. The other thing we've done is cross-sector collaboration, really looking at working with other agencies like healthcare agency and other agencies that actually take the same approach, right? We want to make sure that we're not referring people to being careful, I guess, about that. We're really thinking about how can we set people up for success and all of the resources that they're getting. The other thing is we do a lot of crisis planning for transition. So when people are moving into housing, to Lisa's point, really making sure we're kind of being proactive with folks as they're taking on these new phases of their life, and recognizing that can be really triggering. So we do warm handoffs. We do a lot within Friendship Shelter. We have so many different programs. So we do a lot of like overlapping and warm handoffs, where one case manager, say from a navigation, will introduce the housing stabilization case manager a month in advance for when they're going to get housed, so that we're making sure that there's like a seamless transition into housing. We found that to be very useful. And again, as a way to sort of reduce the stress and trauma of the new transition of like maybe moving from a shelter and into housing. And then last, I would like to say, training and workforce development is a big piece for us. And we're not only, this is hard work, right? And so we have to think about things like secondary or vicarious trauma that happen to staff who do this kind of work, and day in and day out. And so this idea of being able to support our staff and with adequate training and just the recognition that this work is hard, and how do we support? And so, we make sure we have fun. There's a lot of things that we do as an organization to support and offer, mental health services to our staff, so that they can have what they need to be supported in this work, because it's not just about the folks that we're serving, it's sustaining and making sure that we can, keep a workforce that can do this work and continues to thrive in this work. So those are some of my thoughts. I could talk more about it, but I want to give time for other folks.
Yeah, Heather, I'd love to invite you into this part. So much of what Be Well has been doing has been making that shift from bringing services to people as opposed to making people come to services. And so would love to hear more of your insights around trauma-informed care.
Yeah, again, this is in partnership with Friendship Shelter, but the Be Well mobile team, for example, is in different cities, and they're really trained and staffed to respond to a behavioral health crisis for someone who's, whether they're in a private home or they are on the street. Their job is to respond to those crises. They are not trained to be, homeless case managers or really take on that piece of the work. And so again, a little bit of a pilot program here, but we're starting to align the work of the mobile teams with the work of our homeless services. And so when the mobile team, they're out on the streets 24/7 roaming around, and when they identify someone who's willing to accept ongoing services post the crisis moment that they are in, they are then connected with Mia and her team. And we do, I would say a very close, warm handoff there, because oftentimes, because of the length of time that it takes us to house someone, Mia may be able to enroll our individual who the mobile team identified on the street into housing navigation services, but that person remains on the street while we work through a housing plan and housing placement. And that can take some amount of time. I would second, third, and fourth the need for more housing, and we just don't have it available to us. And so it's a lengthy process. So while the mobile team is continuing to be on the streets of our communities, they can help me as team make sure that we continue to know where that individual is who we've enrolled in services. So I think aligning all of these different components of our system and finding ways where we really can collaborate and work together really benefits the population we're trying to serve. And sometimes it's not easy. We work through all sorts of challenges, but at the heart of it, the mission is to serve those who are vulnerable and need these services. And so again, we're in a kind of a pilot phase of this to learn how it's going to work, how you serve in community when you're trying to deliver services to a person and meet them where they are versus ask them to come meet you where you are. That takes creativity, and it takes flexibility on all of our parts to figure out how to devise that in a meaningful way that is both effective for the person who needs help, but also efficient in terms of delivering those services. So that's another sort of area where we've stepped into, and we're trying to learn about services in the community versus within a facility itself. And so more to come on that one. It's new for us, but we're trying.
Thank you, Heather. And I will reiterate again what both Heather and Mia and Lisa have said, that housing and homelessness, highlight, underscore, that we know is so important. And it's the crucial component that, that's where we're headed. And so let's talk about what is the impact when somebody regains housing? How do we see this affecting their mental health? What changes do we see? Lisa, let's get us started.
All right. I think it is life-changing for most people. And others, it's really challenging. They've gone from an environment where there were no rules, or, it's just, they're not safe, to a place where they're not familiar with. There's a lot of rules, there's a lot of responsibility, and expectations, especially within affordable or permanent supportive housing, where there's different funding sources that have different requirements, and it can be a lot. It can be a lot, but and I think that's where supportive services on site in any kind of housing situation is so important to help people navigate that. And once they are supported and they're comfortable and they feel safe, the possibilities are endless. It is just so awesome to see people come up, even to me, 5-10 years later, and like, you have no idea how much this has affected my life and how great things are now, and how I've gotten married, or I've had kids now, or I have a job, or, I have a dog, anything. It's just, it's just so like, oh my gosh, like it warms my heart and it makes every single thing that can be frustrating, doing this work like worth it to help even one person. And I think that is the true testament, is that it's not going to be 100%, right? Not 100% of people are going to be um, successful, and they might need a couple tries, but most people are, and it's life changing and it's wonderful. So I'll stop there.
Yeah.
Yeah, I think, I mean, obviously all Lisa said is true. I think one of the things that we see for people, especially people who are experiencing mental health, whether it's moderate or severe, mostly a lot of people we work with have severe, is, taking a housing first approach. They may not even be in treatment before they get to the housing that we're offering. And what we've seen time and time again is that people then, now that safety is taken care of, right? Now that they can let go, right? And be in this space and be supported in that space, that's when oftentimes we can get people over time to even consider talking to our psychiatric nurse practitioner, right? Or consider talking to a clinician at one of the clinics. And that can be just transformative for people. And so being able to sort of take care of the basic needs, for those of you who are in the social services, Maslow's hierarchy of needs, and we're taking care of that basic, like, I don't have to worry anymore. Because even at the shelter level, I might not be able to stay there long. The person next to me might have a psychotic episode, right? There's a lot to shelter life. It's one level of safety, but it's not always what your own place would be, and there's a sense of dignity and a sense of calm that we can just see on, the people's, the way that they change, and lots of tears, as they're opening their doors. But it definitely, and we see the statistics, again, going back to the data, right? We know that, a large percentage of folks on the streets are experiencing mental health conditions, and by getting them housed, they're not becoming homeless, they're staying housed. And so we know that that's the solution. The data tells us that's the solution, right? And so I think we need to just keep going with the data. Thanks.
Heather, is there anything that you wanted to add into this part?
Yeah, I wanted to just maybe kind of tell a quick story about how important, sort of the again, the alignment of services. We were recently referred a woman who was at risk of homelessness. We not only serve those who are literally homeless, but those who are facing risk of homelessness. And she was given an eviction notice by her landlord. She suffered from severe mental health issues. And she was actually brought into the Be Well campus. And while she was at the campus, she, let the clinical team know that, she was facing this eviction notice. It was exacerbating the situation that she was already in. And at that time, the homeless case management team intercepted and said, would you be willing to take services where a case manager, is assigned to you, and let's see if we can work with your landlord and revoke this eviction notice. And with the combination of going through the crisis residential treatment program for 30 days and enrolling in our housing sustainability and tenancy services that can extend up to a year, her landlord revoked that eviction notice. And, she's been now stable for about 5 months. And it really goes to show that, having access to mental health treatment while also having that, stabilizing force of a case manager who's really going to work with you and making sure that you have all of your needs met really can make a difference. And so, we are seeing and experiencing more and more people slip into homelessness for a variety of reasons, but substance abuse and mental health challenges can certainly be one of those factors. And so when we can heed that off and find a combination of help and services that can stabilize the situation, to me, that's just a huge win. And that was a wonderful success story that we hope to continue to repeat as necessary.
Thanks for putting the human spin on what we've been talking about, Heather. We know people have tuned in today because they are eager to learn more and to be part of changing the conversation around mental health and homelessness. How would you advise people who are watching to help be sort of champions of change? Lisa, I'll come to you first.
I think it starts at the grassroots. The county's huge, right? There's always opportunities within the county. There's volunteer opportunities. You could visit the website and under the jobs, and there's opportunities for volunteering in different ways. But I think that we have a lot of contractors, and they do a lot of good work. Got Friendship Shelter. We have, there's a lot. And if that's a great place to start, is grassroots, and with with people that are actually serving our clients, because it can be difficult to get into the county sometimes. It's a process. I recommend anybody who wants to work for the county, go for it. But we have a lot of providers that do such great work, and they need people who care. And that would be, I think, a great place to start, is, in the community, trying it out and see if this is something that you're passionate about, because you never know until you try.
Very true. Heather, how about you? What's your advice?
Yeah, I think one of the things that we can all do to help make a difference is to be willing to have the conversations around it with your neighbors, with your friends, help break down the stigma and sort of the association of those people, right? We're all humans. We all face challenges and barriers in life that sometimes are very difficult to overcome. And I think, I see it in my own sort of social circles at times where it's like, it's those people. Well, it's a person's child, brother, sister, husband, wife. And I really feel like just having the honest conversations helps people to be more empathetic and understanding to what people are going through. And if we're not willing to have those tough conversations, like today is wonderful. It's that really starts to, change the way that we think about behavioral health issues and homelessness issues. So I would say we all have to start with just having the conversation and recognizing we're all human beings.
Thank you, Heather. Mia, how about you?
Yeah, from speaking to grassroots, I think from the very kind of on the street level, when you encounter someone, just talk to them. I think that it's really important when you see people, what has become problematic in our society is that people don't see it's hard to see, right? And so when you see the person on the street who's talking to themselves, there's fear and kind of unknowing and some bias maybe that comes in. But I would say be kind, like you would to the cashier, and say hello and smile, right? So being able to, I think, make it start with yourself in terms of what you recognize with folks, and know that if we treated mental illness like we treat diabetes, right, then we wouldn't be ignoring people on the street. We'd be like, oh, you need your insulin, let's help you. Right. And so I think just keeping that framework of, like, to Heather's point, these are human beings and their family members, right? So we know it's like 1 in 5 or 1 in 4, however you look at it, of folks experiencing this. And so, and then I think in the macro level, again, being open to having projects come in your neighborhood, maybe not protesting them, having conversation, being an advocate for that, right? Like if it does become, if you happen to be on a next door or any of these things, if it does become a question, being of support, right? You don't have to work directly with people with mental illness or, homeless in order to support efforts to house or get services for them. You can vote, you can donate to organizations, right, that are doing the work, right? You can talk to your neighbors about, like, would it be so bad, to have a place, and, or if you know about organizations who are doing a good job of some of these things, referring them to get more information. So I think there's a lot of different ways people can have conversations about this, and also take efforts on their own part to just be more kind and more supportive of being part of the solution.
Thank you. And if anybody is interested in learning how to advocate for more solutions, like what Mia was talking about, we do offer an advocacy 101 class. That's a great place to kind of learn and demystify what it means to advocate for solutions. Anybody would be welcome to attend. We just have a couple of minutes left, but I have a last question that I would love to sneak in here. Is there a resource that you would recommend to anybody who's watching the book, podcast, or something? This would be like rapid fire. So Mia, what would you recommend?
Two things. NAMI is a very good resource website, NAMI, National Alliance for Mentally Ill. Really good resource. SAMHSA also has a ton of good resources if you're interested in learning more about mental illness and best practices related to the treatment. And lastly, I'm currently reading this book, so I haven't finished it, but it's so good. It's called I Am Not Sick, I Don't Need Help by Xavier Amador. And it's about working with folks who may or may not recognize they have either an illness or an addiction, and how we can be partners with them in their journey.
Thank you, Mia. Heather.
Well, I would echo the two organizations. Those were actually where I was going to go as well, NAMI and Sami. So I would echo Mia's comments, and I think that's a great start. And I appreciate the referral on the book.
Lisa, how about you?
So I echo everything people said. If you're interested in permanent supportive housing and learning more about it, CSH Corporation for Supportive Housing has an excellent website with a lot of resources. I would suggest checking that out. And then I would just really quickly make a correction when I was talking about MHSA Proposition 63. It wasn't one. I don't know where I got one from, but Proposition 63. That's it.
Awesome. Well, thank you so much to each of you for taking time to join me today. And thank you to everybody who tuned in. Thank you to everybody who said questions in advance to help shape the conversation and the dialogue that we had today. This brings us to the end of our current 3-part series looking at mental health and homelessness, but I have no doubt this is a conversation that we will revisit and continue as there's a lot to unpack here. So there'll be some information that's going to pop up on the screen about some local resources. So encourage anybody, feel free to screenshot that if that's helpful. We will have future conversations. We host these every month. And so please feel free to stay connected to us to hear about upcoming online community chats, conversations, and dialogues. Thank you so much for being a part of the movement to end homelessness in Orange County. I wish you all a wonderful rest of your day.